The topic is peritoneal dialysis. Let's talk about the pathophysiology. When we talk about peritoneal dialysis, this will mimic the function of the kidneys by using the peritoneum as the semipermeable membrane. Remember, when we talk about dialysis, it's going to be an exchange of the toxins within the blood for the dialysate solution that we're infusing. And we also are wanting to exchange electrolytes and waste products. Peritoneal dialysis involves the surgical placement of a catheter through the peritoneal wall in which the dialysate solution will be infused as well as drained. The client will have the option to do this either continuously throughout the daytime hours or intermittently, which oftentimes will take place at night. There are complications involved with peritoneal dialysis. One of the most life-threatening ones is infection. And this would be in the terms of peritonitis, and this could lead to sepsis. This all has to do with that peritoneal cavity and using that peritoneal membrane for dialysis purposes. We also run a risk of intestinal perforation. This can also lead to peritonitis, which can also be life-threatening in the form of sepsis. When we are performing peritoneal dialysis, there are three phases. There is the fill phase, there is the dwell phase, and there is the drain phase. During each of these phases, it's important that we are following the prescription of what needs to be put in and for how long, and then how long are we going to drain the contents. During the fill phase, this is where we are instilling the dialysate solution. This is prescribed specifically for the client based on what their needs are. In most cases with peritoneal dialysis, the prescription of the dialysate will be that of a isotonic solution, that what we go in should come out. Installation of this dialysate will again take time, and it's run by gravity in most cases. The dwell phase is referring to how long is this dialysate going to remain in that peritoneal cavity. As you can see by the size of this bag, this is several liters of fluid. Most of us would not be able to tolerate all of that being infused at one given time. During this process, the client's abdominal cavity and their abdominal wall muscles need to be stretched. This is why it does take a couple of weeks or longer for the client to get used to that process of instilling this much dialysate into their abdominal cavity. The dwell phase is then again, how long is this dialysate going to remain in this cavity? During this process, this is when it comes into contact using the process of diffusion and osmosis. All the toxins, the extra fluid, the electrolytes, the waste products that are in the blood will now be gravitated into the peritoneal cavity. And during that time of mixing and dwelling, this is when we want to really spend as much time as possible in this dwell phase, that the client is carrying all this extra dialysate solution in their peritoneal cavity. During the drain phase, this is where we will now take the empty bag of dialysate and place it lower than the chest cavity or the abdominal cavity. This is where drainage will now, by gravity, just flow out. All of the waste products. The picture that you're seeing makes it look like it's urine. It's not. So just by the fact that it's a yellow color, it is not urine. It is actually a clear solution, but it is toxins that are coming out, as well as any additional fluid. During this time, the client may be in a seated position, or he may be lying down. Nursing interventions include that the dialysate is warm prior to administration. Again, just think about having a fluid coming into direct contact with the inside of your body. You don't want that to be ice cold. You also don't want that to be hot. With too much heat involved, you could actually cause an internal burn. Therefore, the client is prescribed a specific type of warmer that will be provided to him through the renal supply company. Never use your own home microwave. When assessing the dialysate catheter, we want to always wear a mask. One of the biggest things that we teach in the home to these clients who are performing peritoneal dialysis is sterile technique. One of the very few times that we do teach sterility in the home environment involves peritoneal dialysis. So the client is taught to wear a mask before they are hooking up their dialysate solution to their catheter. Again, teaching them aseptic technique is very important. They will cleanse around the insertion site, as well as cleansing around where the adapter from the catheter will go into the dialysate tubing. We always want to make sure that that dressing around the peritoneal catheter is dry and sterile. Anytime this dressing comes in contact with moisture, it is now becoming an infection risk, and that dressing must be changed immediately. Oftentimes, as we spoke earlier, the client does not tolerate the initiation of this peritoneal dialysis. In that situation, especially in those first couple of weeks, we will teach the client to slow that rate down. We don't want to just stop it abruptly. We want to administer it as the client can tolerate it. This may take longer in the beginning of the process of dialysis than once they get used to it. Again, it's all about that abdominal stretch. We want to keep that drainage bag below the dialysate catheter as much as possible when it is draining. Additional nursing interventions. When to notify the healthcare provider. When there's insufficient outflow. In other words, when what goes in is greater than what has come out. We want an even distribution of this. So if 6 liters was instilled into the client should expect to get 6 liters out, unless the prescription otherwise is noted. And the client would be informed of that. But in most cases, when we are doing the peritoneal dialysis, inflow equals outflow. So what can we do if we find that when this is outflowing, that it's not equating to what went in? Troubleshooting before contacting that healthcare provider. Keep the drainage bag below the client's abdomen at all times. Check for kinks in the tubing, and there is a lot of tubing that goes from the client down to the bag. Change the position by turning the client side to side or assisting them in ambulation. It's okay to walk around with your dialysate bag attached to you. Assess for any signs of constipation and provide options such as a stool softener or anything that might be stronger, such as a suppository may be needed. There are signs of peritonitis to be aware of that you would want to notify the healthcare provider of. Increased heart rate, increased temperature. That is one thing that we do teach the clients to do, is to assess their vital signs and document them every single day on a clipboard. It's almost like a diary to them. So any sign of a fever is one of the earliest signs of peritonitis. If the client is experiencing abdominal pain or tenderness, that's a concern. One thing to be careful about, though, is there is a difference between the pain that they may be having around the catheter site, which may be just a superficial skin infection, in comparison to true peritonitis. So make sure that we are assessing and distinguishing between those two. What goes in is clear, what comes out should be clear. So if there's a cloudy effluent, or effluent as some people may pronounce it, if it's cloudy that comes out, that's a warning sign. This could be bloody, this could be purulent. So anything that's discolored is a concern, and we should be notifying the healthcare provider about that. Again, looking at abnormal outflow characteristics that we talked about to begin with. Again, clear goes in, clear goes out. Always teach that to our clients. Additional nursing interventions include a further assessment of what to do if we suspect peritonitis. We want to make sure that we drain as much of the dialysate solution as possible from the abdomen. Collect the tubing as well as the drain bag. All of that is to be contained into a container. It is then to be sent to the laboratory for both culture and sensitivity. Prepare to administer antibiotics. Now, one of the good things that's happening now with antibiotic administration with true peritonitis is that the antibiotics can actually be administered directly into the peritoneum through the dialysate bag. So the whole process of doing PD does not have to stop because they get diagnosed with peritonitis. Again, we're looking at abnormal outflow characteristics. Is it cloudy? Again, big sign for infection. Is it bloody? Again, in the very beginning, expected during the first few exchanges, but later indicates more of a vascular issue. If there is a fecal brown color, there could be a good indication that there's intestinal perforation happening. Again, alert that healthcare provider. We look at care and maintenance overall. Sterile dressing, sterile connection. And finally, self-assessment is very, very important. We teach the clients that it's so important for them to weigh themselves daily, assess their vital signs, and document both those elements in their journal or on their clipboard so that they can share that information with their healthcare provider as needed.